Thank you. Good afternoon, everyone. I am Dr. Soumya. I am a professor and head of the Department of Pathology from Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapeeth, Puducherry, from India. I am presenting our study on the histopathology correlation of microsatellite instability status in gastrointestinal carcinomas, and it was a pilot study. To start with, the advent of molecular pathology has paved the path to precision medicine in cancer care, and microsatellite instability is a very essential biomarker for the immune checkpoint inhibitor therapy. There are multiple modalities to identify the status of microsatellite instability, of which polymerase chain reaction is used to detect both the microsatellite instability status directly as a consequence of mismatch repair defect, and also to compare the status in cancerous tissue in comparison with the normal tissue. It is rather a surrogate marker for the mismatch repair defect. So, the National Cancer Institute has recommended a Bethesda panel, which is comprising of 5 markers, incorporating 2 single nucleotide repeat loci and 3 multinucleotide repeat loci. Now, the instability of one site is considered as microsatellite instability low status, and 2 or more sites are considered as high MSI. In gastric carcinomas, the microsatellite high status is associated with older age group, female gender, distal stomach lesions, intestinal type morphology, and also with synchronous gastric cancers. Whereas the colonic carcinomas, the microsatellite high status, the instability high status are associated with mucinous morphology, plenty of tumor infiltrating lymphocytes, and also poorly differentiated features in the microscopy. Microsatellite instability high CRCs are found to respond very well to immunotherapy. However, many studies are not done on the morphological patterns of gastric carcinoma in association with microsatellite instability status. Also, there are many geographic and ethnic variations observed in these patterns. In this background, we have started this study to identify the correlation of microsatellite instability status with the histopathological features in gastrointestinal cancers using polymerase chain reaction. The materials and methods used are, we have taken a retrospective or cross-sectional study, and it was conducted with the clearance from Institutional Human Ethics Committee. The sampling was purposive. We have analyzed 30 cases of radical specimens of gastrointestinal tract, which were histopathologically proven for gastrointestinal carcinomas, received from a period from June 2017 to May 2020. The study period was from February 21 to January 2022. We have taken the clinical parameters and the histological diagnosis from the report forms, and they were all documented in a proforma. The paraffin blocks of the representative tumor tissue were taken, and we have retrieved the tissue blocks which were made anonymous to avoid bias. The DNA was extracted from the tissue in paraffin blocks, and it was quantified. The adequate DNA which was quantified was subjected to PCR analysis using 2 primers. One was a dinucleotide marker D2S123 and mononucleotide marker BAT25. The result was visualized by 1% agarose gel electrophoresis. The data were entered into Excel, and the statistical analysis was carried out using SPSS software version 22. The analysis was represented as categorical variables expressed in frequency and percentage, the association between the parameters such as the site of the tumor, the type, grade and stage of tumor in association with microsatellite instability status were assessed by Fisher's exact test. A p-value of less than 0.05 was considered statistically significant. The results were, out of the 30 cases, 12 cases were gastric carcinomas and 18 were colorectal carcinomas in the study period. And the morphology of all were adenocarcinoma. Among the 12 gastric carcinomas, majority of the patients were male with a male preponderance contributing 7 patients out of the 12. The age group was more in 40 to 60 years age group with 8 patients in that group. Antrum was the most frequently involved location, and we have encountered moderately and poorly differentiated carcinomas more, among which even the moderately differentiated carcinomas were most frequent. The TNM staging, most of the patients, that is 9 out of 12, were belonging to stage 2. We have also seen the parameters such as perineural invasion, lymphovascular invasion, tumor infiltrating lymphocytes, the margin status, and the microsatellite instability positive status was associated with all this. Lymphovascular invasion and tumor infiltrating lymphocytes was predominantly seen in 7 patients out of 12. This is a photograph showing a perineural invasion in a gastric carcinoma, and this is a lymphovascular invasion in a gastric carcinoma. In the colonic carcinomas, out of the 18 cases, once again we saw a male preponderance with 11 patients as male patients, and there were 13 patients once again falling into the age group of 40 to 60 years. Ascending colon was the most involved site, and we have encountered moderately differentiated carcinomas more, that is 15 out of 18 cases. We didn't encounter any poorly differentiated carcinomas in this study group. In the TNM staging, there were 9 patients falling into the stage 2 of TNM. Once again, the lymphovascular invasion was seen in 9 patients, and the tumor infiltrating lymphocytes was seen in 11 out of 18 patients. The microsatellite instability was positive in 13 cases out of 18. This was the morphology of a mucinous carcinoma with intraluminal pools of mucin and intracytoplasmic mucin in a colorectal carcinoma. And this is showing tumor infiltrating lymphocytes in the around the tumoral glands. The correlation of these parameters was done with the status of microsatellite instability, and the positivity of microsatellite instability status was observed in 7 out of 12 gastric carcinomas and 13 out of 18 colorectal carcinomas. In this group also, moderately differentiated carcinomas were more associated, with 6 cases in gastric carcinomas and 12 cases in colorectal carcinomas. Stage 2 disease was most positive in microsatellite instability, with 6 cases in gastric carcinomas and 7 cases in colorectal carcinomas. However, these findings were not statistically significant, whereas we have found that the lymphovascular invasion in gastric carcinoma was significantly associated with MSI positive status. Also, the tumor infiltrating lymphocytes in colorectal carcinomas was significantly associated with MSI positive status. So this is a table showing the parameters. In this, we can see that the lymphovascular invasion, which was present in 7 cases, all were showing positive association with microsatellite instability status, and the p-value was 0.0013, and it was statistically significant. And in colorectal carcinomas, the tumor infiltrating lymphocytes, which was present in 10 cases, was positive for microsatellite instability, and it was statistically significant with a p-value of 0.047. These are the gel electrophoresis images showing the amplification of dinucleotide marker in 220 base pairs, and this is the amplification of mononucleotide markers in 190 base pair. Coming to the discussion, we have totally studied resected specimens from the gastrointestinal tract of 30 samples, among which 12 were gastric and 18 were colorectal carcinomas. The histopathological findings and the microsatellite instability status of our current study was compared with the earlier findings from the literature. In the gastric carcinomas in the earlier studies, microsatellite instability high status was detected more in males with less than 68 years old, intestinal type morphology in the stage 3 disease, and the nodal state was varying from N0 and N3 with poorly differentiated morphology distal location, and tumor smaller than 5 centimeters. In our study also, we have identified more of male preponderance, and the age group was 40 to 60 years. And we have also encountered more number of intestinal type morphology. However, the stage was identified to be stage 2 in most of our patients. The nodal status also was variable, and we also saw a similar finding. In our study, poorly differentiated carcinomas were not much, and we have identified more number of moderately differentiated carcinomas associated with microsatellite instability high status. The distal location, that is the antrum, was seen common in our patients also, but the tumor size was very much variable. Here, once again, we can see another finding that in many of the earlier studies, depending on the location from where they have done the study, the preponderance in the gender was documented in different manners. In some studies, there were more of male preponderance, and in some studies, female preponderance and an elderly age group was documented. However, this study, what I have taken for comparison here, was an Indian study where there was a male preponderance and a lower age group was identified. Coming to the colorectal carcinomas, the microsatellite instability high carcinomas were located in the colon, poorly differentiated morphology, a good number of tumor infiltrating lymphocytes, mucinous pattern, and stage 3 disease was identified in the earlier studies. In our study also, we have encountered more number of ascending colon carcinomas. However, poorly differentiated carcinoma was not encountered in our study. We have also identified increased number of tumor infiltrating lymphocytes associated with MSIH carcinomas. Mucinous carcinomas were 9 carcinomas and all were associated with MSI high status. Stage 3 carcinomas were not much in our study group. Based on these comparisons, we have identified that tumor infiltrating lymphocytes were not significantly associated with microsatellite instability positivity in gastric carcinomas, whereas it was a very significant association in colonic carcinomas. In mucinous carcinoma, the frequency was not in all the MSI positive cases. We have also seen MSI positive cases in the villo-glandular pattern also. The margin status and the depth of invasion were not showing any association with microsatellite instability status. And since we have not encountered any poorly differentiated carcinoma in this particular study group, we could not assess the status of microsatellite instability in this particular differentiation. In gastric carcinomas, there are 4 molecular types which are identified so far, and they have observed that microsatellite instability gastric cancers are forming a relatively small number of patient population. And also, there is no specific panel of markers to determine the MSI status in gastric carcinomas. And both in gastric as well as in colonic carcinomas, they have observed that the detection of MSI is influenced by the number of markers we are using for the identification. One of the Indian studies conducted in 2021 by Chakrabarti et al., they have used nearly 10 markers in gastric carcinomas to detect the microsatellite instability status. So it says that the number of markers is truly influencing the detection of microsatellite instability status. So critically appraising our study, we could say that the variations in the pattern of MSA expression in our study may be attributed to it being a pilot study, and only a retrospective single center study was carried out, and there may be geographical variations as observed in the previous studies. Another aspect is, since molecular testing for MSA is expensive, and also we conducted this study in the pandemic period and it was very difficult to procure the primers, we have taken only 2 markers instead of the recommended panel of 5 markers. And because it was only a pilot study, we thought we will start with the 2 markers and then see the association and then go for a full-blown workup. The conclusions is from our observations are The carcinomas with positive microsatellite instability were predominant in the antrum of stomach, that is the distal stomach, and also the right side of colon. Tumor infiltrating lymphocytes were correlating very well with microsatellite instability positivity in colorectal carcinomas, and it has a role in clinical implications on immunotherapy. Lymphovascular invasion, which is one of the prognostic parameters in gastric carcinomas, is associated with microsatellite instability positivity, and hence it may have a role in prognostication. So we recommend that microsatellite instability can be incorporated as a prognostic test in gastric carcinomas and as a diagnostic test in colorectal carcinomas. And also, we would like to recommend that multiplex PCR panels or next generation sequencing are necessary to enhance the sensitivity and accuracy of the microsatellite instability status. These are my references. Thank you.
From the Third International Conference on Cancer Therapy. I'm Dr. Sumaya. I'm Associate Professor in Pathology Department, Faculty of Medicine and Health University. My talk will be on the molecular pathways that common to be activated in cancer, not only prostate cancer, but also as most of the talks describe, maybe in breast cancer, in urinary cancer, most of the cancer may show this activation of these pathways. This pathway, my study is molecular immunohistochemical study, including EGFR, epidermal growth factor receptor, HER2-NEU, which is another epidermal growth factor receptor 2, and their activation pathways, including ERK, which is the effector for RAS/RAF/MAP kinase, and other pathway activated through these molecules, which is AKT-mTOR, and the interacting PTEN, which is tumor suppressor gene for this pathway. In prostate cancer, I study prostate cancer in my research, not breast cancer. First of all, this is Egypt. We will come you in Egypt, inshallah. This is the pyramid and the Sphinx, one of the most common places in Egypt. Why I choose prostate cancer? Prostate cancer, one of the most common malignancies. This is the most common cancer in men. And this is the third common cancer now, malignancy, and the 8th cause of cancer death. So it represents a major health problem. Really, prostate cancer more common in African men than in Asian men. What are these molecular pathways? Just to have an idea about these molecular pathways, EGFR, which is epidermal growth factor receptor, and HER2-NEU, which is epidermal growth factor receptor 2, are receptors that can stimulate the cell proliferation. So once they are upregulated, this will make the cell proliferate. They can act by two pathways through activation of signal transduction molecules. The first pathway is RAS/RAF/MAP pathway. Any of these molecules, if activated, can also induce cell proliferation, and can act by another pathway, which is the AKT-mTOR pathway. And this is also signal transduction molecules, once activated, also will induce cell proliferation. This AKT-mTOR pathway can be inhibited by PTEN, which is a tumor suppressor gene. If it is activated, it will induce tumor, it will inhibit the cell proliferation. So loss of PTEN is can stimulate the cell proliferation. So the end result, if we activate EGFR, HER2-NEU, or any of the molecular markers, RAS/RAF/MAP, ERK, or AKT-mTOR, or loss of PTEN will induce cell proliferation. Just a few notes about each of these molecular pathways, starting with the ERK. What I want to say, and this is not that simple, these molecular pathways are not that simple as we say, just RAS/MAP, ERK pathway. There are many isoforms of these molecules. For example, the MEK can be present in the form of MEK1 and 2, ERK can be present in the form of ERK1 and 2, and all these molecules can present in the form, not activated form, in active form, non-phosphorylated, and can present in active phosphorylated form. ERK is stands for extracellular signal regulated kinase, because as I say, it transfers the signal from the receptor on the cell membrane to the nucleus to allow the cell proliferation. Regarding the other pathway, which is the AKT-mTOR pathway, this is a serine cellulose kinase. What mean by serine cellulose kinase? This is a protein which activated by phosphorylation at serine or threonine amino acid. So serine and threonine, these are the amino acids present in these proteins. Once these proteins are, these amino acids are phosphorylated, this ACT protein will be activated and can perform its function. ACT is called another name, protein kinase B, because there is another protein kinase, A-serine, threonine also, depend on cyclic AMP. The common site for ACT phosphorylation, which is the active form of ACT, at serine amino acid 473. The position of the amino acid serine that will be phosphorylated induce activation of ACT is the position 473, or threonine 308, the amino acid number 308 in the protein product. Once ACT is activated, it can activate another molecule, what we call mTOR. mTOR also, there are two isoforms, mTOR complex 1 and there is mTOR complex 2. So from this, we can find that ACT mTOR pathway is a complicated pathway. It is not just simple ACT. We have the inactive ACT and we have the activated phosphorylated ACT. And even the ACT, there is the ACT 1, 2, and 3. According to previous researches, ACT1 was expressed in more than 50% of prostate cancer, and ACT3 was found to be expressed in androgen receptor deficient prostate cancer. And this means that these cancers are the castrate-resistant prostate cancer, and this is our target for research, because castrate-resistant prostate cancer had no more efficient therapy. And we just follow up the patient until die in peace, not in pieces. But these patients definitely need further treatment, and we need to find efficient therapy for these patients as they not respond to the classic treatment of anti-hormonal therapy. Regarding the mTOR, mTOR is the abbreviation or stands for mechanistic or mammalian target of rapamycin. The past can mammalian target, then it becomes mechanistic target of rapamycin. This also is a serine threonine protein kinase. Also, the common site for activation is the serine amino acid at the position 2448 in the protein. Also, as we said before, and it can, once it's activated, it can stimulate the cell proliferation, because this is a proto-oncogene, can induce the signal transduction from the cross receptor to the nucleus and allow the cell proliferation. And as I say, mTOR can be present in two forms, mTOR complex 1 and mTOR complex 2, and the active form is a phosphorylated form. So mTOR can be present in two forms, active phosphorylated form and inactive not phosphorylated. Just short note about mTOR. mTOR was discovered in 1960 in the researchers at island called Easter Island, which is known by its inhabitant as Rabanui, discovered this molecule on a soil bacteria called Streptomyces hygroscopicus. This molecule found to have antifungal effect. And because it's discovered in this island, which is called Raba, they called it rapamycin antifungal, antimycotic rapamycin, due to its original from the island and due to its effect. Then this molecule have many studies done on it, and they found that it has very strong anti-immunosuppressor function and approved by the Food and Drug Administration to be used in after kidney transplantation. And then further study done on this molecule, and they found that this molecule can stimulate the cell proliferation and has very important role in cell proliferation and regulation of the cell growth. And they found the different molecules of mTOR, mTOR complex 1 and 2, mTOR complex 1 present in the cell membrane of the lysosomes. Regarding the interacting PTEN, PTEN, this is a phosphatase antensin homologue. This is a tumor suppressor gene present on the long arm of chromosome 10, 10q23, region 2, band 3. Why it is a tumor suppressor gene? Because it inhibits, as Dr. Noor in her talk, it acts on phosphatidine inositol trikinase, ACT mTOR pathway. It prevents the development of phosphatidine inositol triphosphate. So preventive activation of ACT mTOR pathway, and so it prevents, once it's present, it will prevent cell proliferation. So what we study in tumor, loss of PTEN, not the expression of PTEN. Normal cell will express PTEN, but in our study, we study the loss of PTEN because this is a tumor suppressor gene. really, many studies go on these molecular pathways in the different cancer, and this is one of the paper study RAS, RAF, MEK-ER pathway, and also the phosphatidyleinostol kinase PTEN AKT-mTOR pathway, rationale and importance to inhabiting these pathways in human health. So these pathways become extensively, all the people try to study, or researchers study this molecular pathway in different cancers. Why we study the molecular pathway, and we want to know what is the exact molecular mutation that happen in different cancer to use for a target therapy. And once we discover any molecule muted in any cancer cell, the researcher found the inhibitor of this molecule that can be used in a target therapy. And this is another paper that start to study these molecular pathways and found the inhibitor and use the anti-cancer therapy for these molecules. So the target of to know exactly what is the molecular marker that muted in the cancer cells is to prepare antibody for this molecular marker and can be used as a new target therapy. And really, nowadays, we have many target therapy used. You know that the target therapy much better than chemotherapy, although it is used till now in the end stage diseases because it can be used oral. It has less side effects, and I think it's still very expensive, but it's very important. For example, EGFR, we know that we have cetuximab as can target EGFR. And for RAS, RAF-MEP kinase, we have many inhibitors, for example, silomelatonin for MEK inhibitor. And also for the AKT-mTOR pathway, also we have many inhibitors that now in use as for mTOR everolimus, it can be used for mTOR inhibitors. So these molecular markers are very important because it's well studied in the different tumors and have to be studied in all the tumors, because once we discover what is the gene that's muted in this tumor, we can use a target therapy, and we can save many patients, especially, for example, in castrate-resistant prostate cancer, who have no more optional treatment till now. Why we need to study both pathways together? Because if you block one pathway, this may activate the other pathway. So if I use target therapy for only one pathway, the other pathway may be activated and overcome this blockage, and so I will get many very limited benefits from the target therapy. That's why it's better to block both pathways with combination of signaling inhibitors. This will give more efficient anti-tumor effect rather than to use one target therapy for one molecule. So it's better to study both molecular pathways in any tumor, and that's why we study both molecular pathway in the prostate cancer cases. What is the aim of this research? So we want to see the immunohistochemical expression of EGFR, epidermal growth factor receptor, and HER2-NEU, which is called epidermal growth factor receptor 2. This is our proliferation markers because oncogene that once stimulated can stimulate the cell proliferation, and the signal transduction proteins that can be activated whether by the pathway of RAS, RAF, MEP, ERK pathway. So we study one molecule, which is the end effector of this pathway, which is the ERK, and whether activated, phosphorylated, or inactivated. And we study the second pathway, AKT-mTOR pathway. We study the P-AKT, the active form of the AKT at serine 7473. And we study the mTOR both active and inactive, the activated one at the phosphorylation at serine 2448. Along with the interacting PTEN, and for the PTEN, we study the PTEN loss. As I say, PTEN is a tumor suppressor gene. So once it's lost, this means cell proliferation. And we want to correlate this with the clinical pathological parameter of the patient, especially castrate-resistant prostate cases, because these patients need definite another new target therapy that can benefit from. What we do for the material and method, we collect 166 cases of prostatic acinar adenocarcinoma cases. For the pathologist, we have formalin-fixed paraffin-embedded tissue blocks. These cases really, I was working in collaboration with people in Sultan Qaboos University and Armed Forces Hospital. So these cases are collected from Oman. And then we select a core about 1 or 2 millimeter from the paraffin block that shows the cancer. From each case, we take 2 cores because we are worried and 1 core may be lost during preparation. This is the slide we prepare. We prepare a mega block contain many of the cases in the same block that we can study more and more cases. We apply the antibody for these molecules labeled by dye, brown dye called DAB. If these molecules are present, the brown color will appear on the tissue section. If the molecule are not present, this molecular marker are not present, the no brown color will appear in the section. This is called immunohistochemical study. And we assess the protein expression of this molecular marker. You know that there is a gene, and once it's activated, it have translated messenger RNA, and this messenger RNA can be translated into protein products. I study the protein product of this molecular marker, EGFR, HER2-NEU, ERK, active and inactive form, phosphorylated ACT, which is the active form, and mTOR, the active phosphorylated and the inactive form, as well as the PTEN loss, as it is a tumor suppressor gene. This done was a control group. Then the interpretation of the results was as negative. There is no expression of this marker, or less than 5% expression of these markers, and or there is a low expression of this marker or patchy if less than 50% of the tumor cell express this marker, and high expression if more than 50% of the tumor cell express this marker. There is طبعا exception, which was EGFR and HER2-NEU, because according to ASCO and CAP, HER2-NEU should be more than 10% of the cell complete strong membranous stain, and for EGFR, more than 10% of the cell, the neoplastic cell show cell membrane and cytoplasmic stain. Then we try to do correlation between these markers and the clinical pathological parameters of the patient, and we have a special consideration on castrate-resistant prostate cancer, because this is our target from the research to find more target therapy for these patients. What are our results? Regarding EGFR and HER2-NEU, most of the cases were negative for EGFR, HER2-NEU. Only 2 cases express HER2-NEU, and only 12 cases express EGFR. This means that these molecules are has limited value, limited role in prostatic acinar adenocarcinoma. And so even the target therapy for these molecules may be very limited in treatment patient with prostatic adenocarcinoma. Regarding ERK, in the first pathway, RAS, RAF, MAP, ERK pathway, most of the prostatic adenocarcinoma cases were positive for ERK, both active and inactive form, denoting activation of this pathway. Moreover, the active phosphorylated form was present in the nucleus. The transfer of this signal transduction protein from the cytoplasm to the nucleus, denoting activation of this protein, because it passes to the nucleus to stimulate transcription factors to start cell proliferation. So this finding suggests activation of RAS, RAF, MAP, ERK pathway in prostatic adenocarcinoma cases, and potential use of to be used as a target therapy is suggested. And this is the table for our result. EGFR was expressed in 12 cases, whether low expression, patchy, or diffuse. HER2-NEU was expressed only in 2 cases. The phosphorylated active ERK was expressed in about 79 cases, and the inactive ERK was expressed in about 80 cases. And this is the slide, immunostain slides. As I informed you, this is the immunohistochemical study. I use antibody labeled with the DAB, which is a chromogen. If the brown color appears, this means positive study, a positive result. If no brown color appears, this is a negative result. For HER2-NEU, should be complete strong membranous stain in neoplastic cell in more than 10% of the cells, but very few cases show HER2-NEU expression. For EGFR epidermal growth factor receptor, only 12 cases, and also these 12 cases were weakly express EGFR. There is a weak membranous and cytoplasmic stain, and in few number of the cases, so these two molecules mostly are not muted in prostatic adenocarcinoma, and the role of target therapy may be limited for EGFR and HER2-NEU in prostatic adenocarcinoma. Regarding ERK, both active, phosphorylated, and inactive, there is cytoplasmic stain, positive stain, for inactive ERK, and for the active phosphorylated ERK, there is both the cytoplasmic and the nuclear staining. This means activation of this pathway in prostatic adenocarcinoma, and so suggests role for inhibitor for ERK and MEK inhibitor in prostatic adenocarcinoma. Regarding the second pathway, which is the AKT-mTOR-PTEN and the interacting PTEN, the AKT was expressed in most of the prostatic adenocarcinoma, more than 95% of the cases. So this suggests active activation of this pathway, and use of target therapy for AKT may be efficient. Also for mTOR, we study both inactive form and the active phosphorylated form. And we found also that the active phosphorylated form give more strong stain than the inactive form. That may suggest that the inactive form is changed into the activated form during the cancer progression, and this also denoting activation of this pathway in prostatic carcinoma. Finally, PTEN, which is a tumor suppressor gene, and as I inform you, loss of PTEN is the positive result, because the PTEN suppress the cell proliferation. If it is lost, it will allow the cell proliferation. So loss of PTEN expression was found in about 55% of prostatic adenocarcinoma cases. So it has also a role in prostatic adenocarcinoma, but less than AKT and mTOR activation pathway. And this is a table of our results. Inactive mTOR was present about 138 cases, whether low expression patchy or diffuse expression. And for the active mTOR, it was expressed in about 143 cases, whether low patchy expression or diffuse expression. And for phosphorylated AKT, it was expressed in 139 cases. And for PTEN loss, it whether negative, complete loss, or patchy expression. So there is some tumor cells lost PTEN. Whether this the patchy loss denoting the appearance of more aggressive subclone, this is need further study. But the total number of the cases with negative or low expression, that means in some of the tumor cell lost PTEN expression, was about 74 cases. And this is the interpretation of AKT. There is a diffuse cytoplasmic stains in most of the tumor cells, and this denoting activation of AKT. And this is for mTOR. The above images, this is for inactive mTOR, which show weak cytoplasmic stain of the tumor cells. And for the below image, this is the strong cytoplasmic stain for the phosphorylated mTOR. This denoting activation of mTOR and the change of the inactive form into activated form. And this is also denoting activation of this pathway in prostatic cancer cases. And this is to compare the same focus in prostatic adenocarcinoma. One focus show weak cytoplasmic. This is a weak cytoplasmic stain. This is a tumor infiltrating tumor cells. Take weak cytoplasmic stain for inactive mTOR, and this is the same tumor cells take strong cytoplasmic stain for the activated mTOR, denoting the activation of these pathways. Regarding PTEN loss, this is a cribriform prostatic adenocarcinoma. There is loss of PTEN, and this is a positive result because this is a tumor suppressor gene. And this is another case of prostatic adenocarcinoma, but showed retained expression, cytoplasmic or nuclear expression. And this is other cases for prostatic adenocarcinoma in which there is retained expression, whether cytoplasmic or nuclear stain for PTEN. Regarding the correlation of the tumor markers with the clinical pathological features of the patient, unfortunately, there is no significant correlation was found between these tumor markers and the clinical pathological parameters of the patient. And as I say, we can our target to assess the castrate-resistant prostate cancer and any significant correlation, but unfortunately, our study found no significant correlation for castrate-resistant prostate cancer cases. One of the positive results that we find the significant correlation between the activated mTOR, the phosphorylated form, and the activated AKT, the phosphorylated form, and this is what expected because AKT is the one which activates the mTOR pathway. One of the findings that needs further research, we find that the activation of mTOR pathway not correlated with the PTEN loss, although, as I discussed in the beginning of the talk, PTEN loss should activate the mTOR pathway. Maybe there are two different insults. One can affect PTEN, lead to PTEN loss, and another insult can activate mTOR. As I inform you that these pathways are very complicated and there are many other interacting molecules. Mostly there are more molecules that need to be further studied. So what is the conclusion? According to this research, EGFR, epidermal growth factor receptor, and HER2-NEU are mostly limited expressed in prostatic acnal adenocarcinoma, and so to be used as a target therapy may be of limited value. However, there is activation, this study suggests, and there is activation of AKT-mTOR pathway and the RAS, RAF, MAP, ERK pathway, and so the patient may get benefit from the new target therapy that can attack this pathway, RAS, RAF, MAP, ERK, MEK inhibitor, and ERK inhibitor pathway, and also the patient may get benefit from mTOR inhibitors and AKT inhibitor as a target therapy. As we didn't find a significant correlation between the activation of these pathways and castrate-resistant prostate cancer, so what is the target therapy that best used for castrate-resistant prostate cancer? Our study cannot determine which is the best one to be used as a target therapy in castrate-resistant prostate cancer. As I say, also as in PTEN loss, we didn't find the correlation between PTEN loss and mTOR activation pathway. So we suggest, and there is different insults can affect these pathways, and there are more molecules interacting in between. That's why the correlation cannot be appreciated. But we have a recommendation. First of all, when we try to study these immunohistochemical markers, we need to do proper interpretation. We search so much on the previous studies to assess how we do best interpretation. We find many variations and different interpretations till now. So definitely interpretation of immunohistochemical marker expression vary and according to specific context, tumor type guidelines used by the pathologist. We need to do standardization for this interpretation first of all. But this is the first issue of the first problem we have to consider. Other issue, we find that there are many researches also going on segregate the expression of these tumor markers expressed, especially phosphorylated ERK and phosphorylated mTOR. They segregate the nuclear expression from the cytoplasmic expression. As I inform you, when these molecules go to the nucleus, this denoting activation of this pathway because it starts to go to the nucleus to induce more transcription factor instead of the cytoplasmic stain. I found many papers after we finish our research segregate the expression whether nuclear and cytoplasmic. For our cases, we gather the nuclear and cytoplasmic stain together because most of the cases was both nuclear and cytoplasmic, and very few cases that showed the only nuclear stain. The most important issue from my point of view is the molecular study of this immunohistochemical marker. As I inform you, we studied this marker on the protein level, but we didn't study the gene level or even the transcripted messenger RNA. Study of these molecular markers by PCR, polymerase chain reaction, or DNA sequence is definitely are needed because we need to know what is the actual mutation that happen in these molecular markers. As you know, EGFR, epidermal growth factor, the mutations that happen in lung adenocarcinoma totally differ from the amplifications that happen in colon cancer. The mutations that happen in lung adenocarcinoma, deletion or insertion or substitution in different exons, exon 19 or 21 or 20. However, amplification happen in colon cancer, and so the target therapy used in lung adenocarcinoma will differ from the target therapy used for colon cancer. Also, post EGFR target therapy, but this will depend mostly on the subtype of mutation. So it's very important to supplement this research by further molecular study.
Daniela Winicka. I am from Poland, and I will be talking about new therapy, but I am pedagogue and social therapy. So it is no medical side, but it is a psychologist side. But I think that maybe it will be interesting for you too. I will be talking about my experience and about my observation work in this new therapy. It is snoezelen therapy as a proposal of therapeutic activating children with the cancer, because I was work a few years on Department of Bone Marrows on hematology and pediatric oncology. So I hope so that it will be for you interesting. Okay, what I will be talking about? The first, I talk a little about the situation of a child with the cancer, because we know now that the treatment of cancer is very aggressive for the person who are on development, very fast development. It is about children. And the second, I will be talking about what is the snoezelen room and what is a multisensory therapies, and with our hospital in Wrocław in Poland. So the next, I will be talking about our new machine. It is something like a snoezelen card. It is something like a mobile snoezelen in patient's room, so we can do therapies in patient's rooms all the times. And the next, recipients and the snoezelen activity forms in our hospital. I talk about a little bit about my experience and my observation. And the last, it will be the use of snoezelen in hospital and its effects. So the children with the cancer, we know now that it's a very difficult situation for the child when they have more intensive development, and they have a cancer. So the first, it is isolation from natural environment. In my hospital, sometimes it is 3 months, sometimes it is 9 months, sometimes 1 year. So it is a long time for a little child. And the second, it's lack of intimacy, lack of peace and quiet, and more stress because of the treatment. The next, lack of autonomous decision and acting. All the times the children are with the medical personnel, and sometimes with the parents, and only adults, no any children, only the children who is in the hospital too. Life in the world of adults, I talk about it, limited access to peers, deprived of basic childhood attributes, and no possibility of development connected with child's activity and movement. So it is very important that we have to try find very intensive and very nice and probably protection therapy for the children. What is the difficult is about children with the cancer? It is fear. Fear because of the problems with the self-determination, self-esteem, talking initiative and assertiveness, problem with the acceptance to be touched, communication by touch, because they don't want to be touching. And the second, lack of trust, especially towards adults, and behavior disorders. What does the children need in hospital? Of course, when we think about children, we know that they wanted to be like other children in the same age. So they need a peace and quiet, and sometimes only relaxation because of pain of some treatment and medical activities, sense of safety, stability, predictability, place where they can be normal child, the place who is magical, and they can possibility of expressing themselves. So they need dreams and desires, and little be only to simply be child. So the snoezelen room is the place when the where the people, all people, because adults too, and the children have to be a child. So snoezelen is sometimes the only place during treatment is very safety for children, where participants freely and safety play and rest, which is quiet, harmonious, nicely looking, because it is a little bit magical place. I think that maybe you will be look on the picture, so I show you why it is a little bit magical place, and it's not resembling a hospital, where the children feel safe, where they feel fully accepted. What is the role on the therapist with the children on cancer? The role is one, very important. In the role of activating the child during the treatment and setting the requirements. Why it is very important? Because we try to do everything that the children, when they will be after treatment, can come back to environment, natural environment, to school, to kindergarten. So it is very important do everything on the before during treatment that activated this person. So each patient should be activated in the same way as before outside in the hospital, and like his friends in the same age. Activation should be adjusted to age and the child's possibility, because sometimes, of course, our children couldn't move or don't feel good. So we have to prepare our snoezeling room in the same. It is possible to be safety for everyone. Each activity is immensely important, but the attractive one is much more preferred. We know that playing is the best activation for the children, so we try do everything that our therapist, it was very attractive for everyone. And the snoezeling room is the place when we can do more very attractive playing and game and everything what we want. Of course, we have to think about the long-term effects of treatment. So it is important to try do everything that the negative treatment effects was less. It is something such as because during treatment sometimes children has aplasia and they feel pain or more stress. So we try to do everything that they feel a little bit better because of therapist in the snoezelen room. What is the elements of in snoezelen room? If you look on the picture, it is our snoezelen room in hospital in Wrocław in Poland. Now we have one big snoezelen room in one hospital and 5 little snoezelen room in other place in Poland. But we have 18 hospitals oncologists, pediatric oncologists in Poland. So we wanted to 2025 we'll do to every hospital in oncologist pediatrics was snoezelen room. What is elements of visual and auditory stimulation? It is a special room where is some elements. It is something like a bubble water column, solar projector, think and thick fiber optics, shimmering curtains, starry night projection, infinity tunnels, sound and light tracks, mirror ball, acrylic mirrors, and many others things. Why the things is very important? Because it is multisensory stimulation for the children. So it was a musical instrument, manipulation and soul panels. So like you saw it, like you see, it is very a very nice place for everyone, because there is a little bit dark and something is light, but light it is if it is possible, it is very delicate or more delicate, and it is very important. Element of tactical vibration, atrial, taste, and olfactory stimulation. Very nice element. It's a water bed and vibration mats, hammock swings, mattress, sensory bags, sensory panels, balls, messengers, natural products, and aromatherapy lamps or stimulator of smell. But we know that it is if it is impossible, we try use aromatherapy, but not always, because sometimes our children has a problem with the smell. You know about it, I think. Okay, and the last our project, it is a card of snoezelen room. It is a machine where the snoezelen room is one element. Why it is very important? Because we can go with this machine, with this card, to room of patient. So sometimes we can do our therapist if the person, the child couldn't be on the snoezelen room because of pain, because of something, a medical side, and maybe they couldn't because anaplasia. So we can go with the card and continue the therapist. Snoezelen, if in hospital activity receptions, it is for everyone, for newborns, for infants, for toddlers, kindergarten and school children, teenagers, for parents and siblings of a sick children, and for the hospital personnel, because we know that it's very important that reduction of stress reduction is very important for medical side too. So we try open the snoezelen room for everyone who are in the hospital, who they work in hospital, and who is because of treatment in the hospital. The second, snoezelen in hospital additional needs. And this is for everyone. It is no limits because it is for the children with disabilities, with emotional and school difficulties, with concentration difficulties, behavior disorders, aggression and autoaggression. Sometimes we relaxation the person who couldn't be couldn't have other therapist, with hyperactivities, because it is very the place in snoezelen room is very safety for everyone, with the sensory disorders, sensory modulation problems, with shy and withdrawn children. Sometimes our children couldn't talk with a therapist, so we try give him a little bit instruction about talk in the snoezelen room, because they it is for children like other place, other like than in other places in a hospital. So it is very safely for everyone. Snoezelen in hospital form activities. It is individual and group activities in snoezelen room, but in group, I think about 5 person, no more, because every person is more stimulation. But I prefer individual therapist because I can use more therapist. It is good forms for family activities. Sometimes we try that the families was meeting in a snoezelen room because it is very safety place. Activization and relaxation in the same time because we try do everything that the person in snoezelen room feel good in this time. Passive stimulation of the senses. Sometimes it is that the children do nothing, only like on water bed and nothing else. And this environment, snoezelen room, is passive stimulation all the times. Very important sentence is nothing has to be done. Everything is allowed. It is true because all the times in the hospital, children have to do something what the medical personnel wanted, and in snoezelen room they couldn't take our instruction. We only open a snoezelen room and be with the children in this place, nothing else. And I told you many times, but I try again. It is magical, intimate, and safety place for the children and for the other personally. And what is very important, that the thematic polysensory activities we have to do in this room. Snoezelen in hospital combining with other methods. For us, pedagogues and psychologists, is very important that we can do in snoezelen room bibliotherapy, horror therapy, relaxation and visualization, art therapy, drama and shadow theater, music therapy, projection methods, thalassotherapy, silvotherapy, horticultural therapy, autobiographical work, and Veronica Sherborne's development movements. So it is the place when we can do more. It is the therapist no limits, I think, because we can do everything in this snoezelen room. And my observation, conclusion, my effects of the work, activation. The most children who has a therapist in snoezelen room, it was a place which is nice for them and pleasant and attractive to be active in. So they wanted to be there, and we try do this therapy. What we can do, it is 2 or 3 times per week. The patients choose activities themselves. It is very attractive for the children, of course. All the activities in snoezelen are in a form of play or game. It's a stimulation to the activity if we can have a form of play. Snoezelen prevents from hospital monotony thanks to attractiveness and a big number of offered activities and devices. And passive and withdrawal children get activated. Children with movement problems entitled the movement. So the activation is very important to think about motorics of children and about them come back to school or kindergarten. And very important thing, in my opinion, is the relaxation during treatment. So the spending time in snoezelen room, the patient experience both self-relaxation and relaxation. supported by the therapist. Overall development during the time spent in snoezelen room, the patient experienced passive stimulation of all senses. Snoezelen room is such a safe place that it is also appropriate for motoric stimulation, gathering developmental experience that are limited by the hospital reality. So it is very important when we think about long-term effects of treatment the children with the cancer. Reduction of pain. In my experience, many persons who are in a snoezelen room don't feel more pain like before. In snoezelen, we conduct relaxation, visualization, and breathing therapies, which can be helpful in reduction of pain. Devices in the snoezelen room and the room layout effectively divert patients' attention from patients' reality, medical, usually and safe environment for the patients. So we try take our children to the snoezelen room before medical site. Stress reduction, because it is a very nice place, so it is a friendly and pleasant place. It appears to be a medical place, a kind of playground, another word where all patients can forget about hospital reality. So it is one place in the hospital where the children can forget that they are in the hospital and is in the treatment. Autonomy it's very important, especially for teenagers. Snoezelen room is the place when insurance therapy participants the freedom of activity. I told you about a very important sentence. Nothing has to be done. Everything is allowed. So it is because of autonomy. It emphasizes and enables patients' autonomous decision, which is very limited in hospital, because in the hospital they can be think and do what they want. And in a snoezelen room, they can do what they want. Safety. It is a very, snoezelen room or snoezelen car is a very safely place for everyone. They can be used by patients with the aplasia and after transplants. Because we try to do everything that the place was very clearly for everyone. And getting the childhood back. I think that it's very important for the children, especially for the young children, but for teenagers too, that in snoezelen room they can make the child be the child. It is very important. Reading together, playing with the use of imagination, singing, making music, group play. So we make the child get away from the adult's world, which brutally steps into its childhood, illness, pain, effects of treatment, clashing with death. So the snoezelen is the environment to be very safely for everyone, and it is the place when the children have to be a child. Fairy tale world, it is very important if we think about children. Relating one's problem with the character's problems enables painless going through one feelings in a safe and secure atmosphere. These are not the child's but the character's problem after all. What is important in a fairy tale world, the fear might take a specific form, dragon, monster, of witch, that it is easier to embrace it or even set oneself free of it. So the fairy tale world is very important for every child and special for the children when they are in a hospital. Snoezelen is the place for the special reduction negative emotions and evoking the positive ones. And the second, regeneration, psychophysical powers, clamping down, relaxing, and play and pleasures, and developing social competence, the room for being with others, meeting the harmonies gently and clearly, positive stimuli, polysensory experience, developing the ability to use all the senses. So snoezelen is the environment for outside hospital meetings, because it is the place who is on the other places in the hospital, strengthening relation, building self-esteem, development of one's strength, building confidence, experiencing beauty, polysensoric experiencing, sharing experiencing emotions, time, being with others. So thank you for attention. I hope so that it was interesting for you.
Hello, estimated college, research and guests. It is my honor to be here at the third International Conference on Cancer Science and Therapy. This conference brings together experts from around the world to share insights, research findings, and breakthroughs in the field of cancer science and therapy. In today's presentation, titled Diagnostic Clues for Hyalinizing Trabecular Tumor on Cytology, we will delve into the nuances of diagnosing this benign thyroid neoplasm. Our focus will be on the challenge of cytology in distinguishing this entity from other malignancies and ensuring accurate diagnosis. Hyalinizing trabecular tumor is an uncommon benign thyroid gland tumor, initially identified by Carnett et al. In 1987. These neoplasms arise from the follicular cells of the thyroid and exhibit certain structural characteristics in fine needle aspiration cytology specimens that resemble those of malignant tumors. These include similarities to papillary thyroid carcinoma, medullary thyroid carcinoma, and non-invasive follicular thyroid neoplasm with papillary-like nuclear features. As a result, accurate diagnosis through fine needle aspiration is achieved in only about 80% of the cases, leading to a high false positive rate of 92%. Such a high rate of misdiagnosis often results in unnecessarily partial or complete thyroidectomies, with the subsequent risk to the patient's health and undue cost. This is a retrospective case series from Hospital Clínico San Carlos in Madrid, Spain. Hospital Clínico San Carlos is a large tertiary hospital with a population over 360,000 people. All fine needle aspiration cytologies are performed under ultrasonographic control, complemented by rapid on-site sample evaluation to enhance diagnostic accuracy. We have performed a retrospective search of all thyroid gland resection specimens diagnosed as hyalinizing trabecular tumor and recorded in the electronic records of the pathology department in the past 10 years. For the aim of this study, we only reviewed the original site and did not perform either immunochemistry or molecular technique in any of the cytology samples. Cytology samples adequacy was assessed based on the Bethesda system for reporting thyroid cytology, which also provides the diagnostic characterization framework for this specimen. Each case involves both air-dried and alcohol-fixed cytological specimen. At the time of diagnosis, Papa Nicolau stain was applied to the alcohol-fixed specimen, and liquid stain was used to the air-dried ones. This study has been reviewed and approved by the Hospital Institution Review Board. Our results are summarized in Table 1 from the article Diagnostic Clues for Hyalinizing Trabecular Tumor on Fine Needle Aspiration Cytology, Over a decade, our hospital has identified 6 cases of hyalinizing trabecular tumor confirmed through histology. The demographic distribution shows a female predominance, with 5 women and 1 man. All patients were over 50 years old, with a mean age of 61.3 years. Interestingly, the isthmus of the thyroid was involved in half of these cases, while the left lobe was affected in 2 cases and the right lobe in just 1. The tumor size ranged from 0.7 to 4 centimeters. However, most of the lesions were no larger than 2 centimeters. Analyzing the ultrasonographic features, all the lesions were solid and hypoechogenic. 2 of them showed microcalcification. Only 1 case had a heterogeneous ultrasonographic pattern, and high intratumoral vascularity was reported in another by the radiologist. Regarding cytological diagnosis, the majority, 5 out of 6, were categorized as either suspicious for follicular heart cells neoplasm, category 4, suspicious for papillary tumor carcinoma, category 5, or positive for papillary tumor carcinoma, category 6. Only 1 case was deemed benign, where the cytopathologist highlighted an abundance of heart cells in the cytological specimen. Notably, none were classified under atypia of indeterminate significance, category 3. All of our patients underwent a thyroidectomy, and only 1 of them was partial. 2 of these patients developed a postoperative hypothyroidism refractory to treatment with thyroid hormones. Additionally, each patient exhibits other thyroid pathologies alongside hyalinizing trabecular tumor. 3 had multinodular Gaucher. 2 were diagnosed with lymphocytic thyroiditis, and 1 patient presented with both conditions. Prior to hyalinizing trabecular tumor diagnosis, 3 patients had previous fine needle aspiration, all of which were categorized as Bethesda 3 for atypia of undetermined significance. Table 2 provides a detailed overview of the cytological characteristics observed in our study cases. All the samples showed a bloody background with little or no colloid, and the smears were hyper to moderately cellular. Only 1 case shows a small amount of dense colloid, resembling the chewing gum aspect of papillary tumor carcinoma associated colloid. A search retrospective review of the slide revealed the presence of an extracellular hyaline material in all the cases, as we can see in these pictures. This material was notably abundant in 2 cases, while in the remaining 4 it was more subtly distributed. It appeared consistently throughout the slides, often encircling cell groups in small quantities. This material was overlooked at the time of diagnosis, probably misinterpreted as dense colloid, with a more homogeneous aspect and sharp edge. 2 of the cases show pseudomatous calcifications, as we can see here and here. Contrary to some thyroid pathologies, none of our cases exhibit papillary structures, fibrovascular cores, or a high number of discohesive cells. The cellular arrangement was predominantly in large monolayered sheets or cohesive clusters of varying size. The cells themselves were characterized by a broad, polygonal fusiform cytoplasm lacking of distinct cell borders. Nuclei were either centrally or excentrally located, maintaining a low nucleus to cytoplasm ratio. Notably, nuclear clearing was absent in all cases. However, pseudo-inclusions and nuclear growths were observed in 3 cases. Nucleoli were identified in every case, with 2 cases exhibiting particularly prominent nucleoli. Hyalinizing trabecular tumor, a rare benign tumor, predominantly affect women between their 4th and 7th decades. Its cellular morphology, including elongated and polygonal shapes, nuclear growths, and pseudo-inclusions, can lead to misidentification as papillary thyroid carcinoma or non-invasive follicular thyroid neoplasm with papillary-like nuclear features, while the background hyaline material might be mistaken for medullary thyroid carcinoma. A notable feature of hyalinizing tumor is its cell membrane and cytoplasmatic positivity for Ki67, specifically when using the MID1 clone and conducting the reaction at room temperature. This characteristic, observed in both cytological and histological specimens, is crucial. Hyalinizing tumor also express thyroglobulin and thyroid transcription factor 1. Weakened focal staining with ectopatiform mesothelial 1 and galectin and are generally negative for cytokeratin, chromogranin, and calcitonin. Recently, a rearrangement of PAX-H with GLAS3 and less frequently PAX-H GLS1 has been discovered only in hyalinizing tumor and not in papillary carcinoma, which could be an useful tool to distinguish both entities. All hyalinizing tumor cases saw a BRAF wild-type phenotype, with a BRAF mutation indicating papillary carcinoma instead. In our series, ultrasound imaging often failed to distinguish hyalinizing tumor trabecular from papillary carcinoma due to similar radiological features, such as microcalcifications. However, Scaglietti et al. Recent reviews suggest considering hyalinizing trabecular tumor when ultrasound indicates benignity but cytology hits at papillary carcinoma. Key cytological indicators include a hypercellular or moderately cellular sample with little or no colloid, absence of papillary or fibrovascular structure, and nuclear pseudo-inclusion that don't align with a specific Bethesda category. This requires careful examination for hyaline material, which can be central in neoplastic cells or in the background, as Scaglietti et al. Reported. Distinguishing hyaline material from colloid or amyloid is crucial, with the latter appearing as irregular acellular fragments that stain differently with Papa Nicolau and deep quick stain, eosinophilic with Papa Nicolau and deep blue with deep quick, and we even suggest the possibility to perform Congo red staining. Distinction between hyaline material and colloid is exclusively morphological. The main problem is to distinguish dense colloid from the hyaline material. Colloid has net blonde edge as droplets and often shows a glass cracking appearance without fibrillary borders, in contrast with the hyaline material of hyalinized trabecular tumor. Ki67 immunostaining and BRAF mutation testing are helpful, but even without this, if hyaline material structures are observed, a note should be made. This allowed for the consideration of a less aggressive surgical approach. The presence of other concomitant thyroid pathologies may contribute to make the correct diagnosis more difficult, and the coexistence with lymphocytic thyroiditis, for example, may push the cytopathologist to give a diagnosis of suspicious of papillary thyroid carcinoma. It is recommended to keep in mind the high frequency of concomitant pathology in hyalinizing trabecular tumor. This study has limitations, including its retrospective nature and reliance on histopathological diagnosis. Some hyalinizing trabecular tumor cases may have been misdiagnosed. Until 2013, our hospital didn't use the Bethesda system for cytology reports, so we have reclassified earlier cases based on report descriptions. Additionally, we had limited access to radiological image and based our analysis on reports, possibly overlooking crucial radiological data. Hyalinizing trabecular tumor is a rare entity frequently misdiagnosed in cytological samples. After reviewing our cases, we feel that the cytopathologist must be aware of the distinguishing features of these lesions, mainly the typical ELE material, and learn how to differentiate it from other kinds of background material. We believe that with a comprehensive knowledge of hyalinizing trabecular tumor and its distinct features, accurate cytological diagnosis are achievable, and this awareness could significantly diminish the need for overly aggressive treatment in these patients. Before concluding, I would like to extend my heartfelt thanks to the organizing committee of this conference for giving me the opportunity to share our research and findings with esteemed colleagues from around the world. Also, a special thanks to Hospital Clínico San Carlos and everyone involved in the study we presented today.
Let me start the presentation. There's something about me before starting my presentation. So I'm Dr. Manisha Regmi. I was born and brought up in Kathmandu, Nepal. I completed my med school from Manipal College of Medical Sciences, MCOMS. It is affiliated to Manipal University, India. I graduated from med school in 2014 and I graduated as MD Pathology in 2020. Since then, I've been a lecturer in Patan Academy of Health Sciences and Pathology from 2021 to 2023. And recently in 2023, July, I joined Westchester Medical Center, New York. I have a working experience of 7 years in pathology, including the residency. And in future prospects, I would like to get involved in hematopathology and oncopathology. Next slide, please. So these are some of my three of my team members that we work together in this case report. So it's I just wanted to mention the names. It's Dr. Prabish Adhikari. He's MD pathology. He works in National Path Lab and the Research Center. It is located in Kathmandu, Nepal, as well as Dr. Rojin Kharka and Dr. Rohit Kharki. They are also involved in the field of pathology in Patan Academy of Health Sciences. It is a medical college in Kathmandu. Next slide, please. So table of contents, I would first start with the introduction, and then I'll proceed towards the case report presentation. Then we will discuss, there will be some discussion regarding the case report and conclusion, and followed by any questions from the audience. Next slide, please. So the topic of my case report was cavernous hemangioma in adult parotid gland encroaching on the parapharyngeal space, a case report that was published in Journal of Pathology of Nepal in the year 2023. Yeah, so everybody, can you see my screen?
Yes, we can see, doctor.
Yeah, I think I can proceed from here. Sorry for the technical issues. So I think we have gone through this. This was the team slide members, table of contents. Yeah,
But,
okay. And this
you can't see the full screen, so maybe you can put it into full view.
full view, sure. Let me see. Okay. Yeah. Is it okay?
No, it's not full view. Yeah.
I shared.
Yes.
How
it is.
It's full view.
Yes.
Okay, thank you. So this was the case report that we published in, that's a topic is cavernous hemangioma in adult parotid gland encroaching on the parapharyngeal space. It was a case report. I was the first author, followed by my team members that we have gone through, and it was published in Journal of Pathology of Nepal in March 2023. So introduction, let's start first with the introduction with the case report. So we reported a case of 54-year-old woman with a left parotid mass. There's a left parotid gland mass of 5 years duration, which was rapidly increasing in size over a year. And magnetic resonance imaging, that is the MRI, was suggestive of a left parotid pleomorphic adenoma invading the parapharyngeal space. So pleomorphic adenoma, it is a benign tumor of the parotid, and fine needle aspiration cytology was done, which was inconclusive, and with a strong clinical suspicion of a pleomorphic adenoma, a left total parotidectomy was performed, that is the left parotid was removed, and the histopathological findings was, however, surprisingly, it was a cavernous hemangioma. So let's start with what is hemangioma. So hemangiomas are benign tumors of vascular origin. The head and neck region accounts for 65% of these benign tumors, involving a variety of tissues like the skin, the muscles, and the salivary glands. So we are concerned here with the salivary glands in this patient. Hemangiomas principally affect salivary glands with the parotid gland as the most common site, 81 to 85% in the head and neck. However, the frequency is only 0.4 to 0.6% of tumors of the parotid. So it is a very rare tumor that occurs in the parotid. Parotid hemangiomas typically occur in children and account for approximately 50% of parotid tumors that develop in the first year of life. By contrast, adult parotid hemangiomas are quite rare. Due to the rarity of this condition in adults, clinical behavior may be quite misleading and less reported, as was in our case. So let me start with the case presentation. So ours was a 54-year-old female who presented to the ENT department of Parton Hospital with a 5-year history of swelling over the left side of the face, which was rapidly increasing in size for 1 year. And the swelling was not accompanied by pain. On physical examination, as the clinicians examined, there was a dumbbell-shaped mass was palpated over the left parotid region. And the mass was non-tender, non-fluctuating, non-pulsatile, and the overlying skin was of normal color, texture, and temperature. There were no palpable masses over the right parotid area or any associated lymph nodes that was enlarged lymph nodes that was detected. So fine needle aspiration revealed blood and its elements only. On MRI, we also did the MRI. So on MRI, a well-defined homogeneously enhancing mass that was the size of 8.6 by 8 by 3.5 centimeter. It is a fairly large size in the left parotid space was identified, which was involving both the superficial and the deep parotid gland with lobulated margin invading the parapharyngeal space. The parapharyngeal space is just adjacent to the parotid gland, so it was big enough to involve the space that was just adjacent to it. And the images that we see here is figure A shows a T1 MRI, which shows hypointense. The intensity is hypointense, and this is the mass that I am showing through the cursor. And figure B shows MRI T2, which shows the tumor being hyperintense. So this is the tumor that we can see. It is white opaque in color. So this is a large tumor that is present in the left parotid gland, and it is encroaching on the space adjacent to it. So we thought of this could be some kind of tumor or something. So there was really concerns about what could be the finding. So following a provisional diagnosis of a benign tumor, we thought that it was a pleomorphic adenoma, a left parotidectomy, it was excised, excision of the parotid was performed. And during the surgery, the macroscopic appearance was of encapsulated and hemorrhagic, well-defined tumor suggestive of vascular lesion. So we can see in this image, so this is the serial sections of the parotid. So it shows a homogeneous and a solid brown tumor. This revealed this could be a vascular tumor. So On microscopy, we just stained the slides, processes, stained it, and then we saw this in microscopy. So the microscopic image showing vascular proliferation of different caliber lined by a single layer of endothelium. You could see here single layer of endothelium with no atypia, and which is supported by thin layer of collagen. And we also proceeded towards staining these cells. These are CD34 positivity endothelial cells. So these confirm that this is a tumor of vascular origin, and the patient is doing well on a 1-year follow-up. So discussion, let's proceed towards discussion. There is still not enough data regarding recent prevalence of parotid gland cavernous hemangioma in adults. So this was the case of cavernous hemangioma. It was a benign tumor of the parotid gland. The 2005 WHO classification of tumors stated about just 50 cases reported globally, mostly as individual case reports. So these cases have only 50 cases have been reported. Since then, only a few cases have been described in the literature. Due to the low prevalence, they are not usually taken into consideration in the differential diagnosis of adult parotid masses. So, pleomorphic adenoma and Warthin tumor are the most common benign tumors of the salivary glands. That's what we thought in this patient. We thought that pleomorphic adenoma was a fairly common condition in adult salivary gland tumors. So we went with the resection of the same. We did not have in mind that it could be a vascular tumor. MRI is useful in demonstrating lesions of the parotid gland and its extension, as was in our case, it was extending to the parapharyngeal space. MRI also helps determine the surgical approach for the tumor and to reveal the relationship with adjacent structures. In conclusion, cavernous hemangioma of the adult parotid gland is rare. Nevertheless, it should be included in the differential diagnosis of salivary gland swellings. Definitive diagnosis, although difficult, can be accomplished through typical clinical presentation and characteristic radiologic findings. So I just pulled up some of the case reports that have been published regarding this rare tumor of the parotid gland. So in different journals, so the SAGE journal has 3 cases of parotid hemangiomas in adults. Another one I pulled up was from National Library of Medicine, cavernous hemangioma of the parotid gland in adults. These are all case reports. Another one I found from Juniper Publishers, so cavernous hemangioma of parotid gland in adults, a review of literature and case reports. So I just wanted to share this presentation, although rare, although benign condition, but we have to include hemangiomas. These are the vascular benign tumors of vascular origin in the parotid gland swellings, and we should always be mindful that it can occur in adults, however, rare. So that concludes my presentation. Any questions?